Auzubillahiminash-shaytanir-rajeem. Bismillahir-rahmanir-rahim. I am Dr. Shahzad Wasim, and I hope you people are doing the best in your health and every field of life. In this video, we will be discussing with the medical students about primary open angle glaucoma. So in this channel you might be finding that some videos are being repeated over and over again with same content or something a little bit different. The reason being for this is that on the basis of the comments I end on my teaching, whenever I feel that students need to know these things, I make the video again, even if I have posted it already, because in every video at least something new comes in the mind, or if not, it will be a revision. So regarding primary open angle glaucoma, I would like to the students, especially of the undergraduate levels and the postgraduate levels also, I would like to remember them a couple of facts which we know about this disease till yet. Number one is that it is almost in most of the cases a symptomless disease. Patient does not have any symptoms, and it can be a silent killer of the visual acuity. And most commonly it is diagnosed when the patient comes to you for some other eye condition, and you check his intraocular pressure or see the fundus retina, and you find the signs of the glaucoma, that is rise in the intraocular pressure and cupping in the optic disc. Otherwise patient does not have any symptom, and his visual acuity is its basics, which is central vision. And as we know, glaucoma affects the peripheral vision, so the patient may not be able to appreciate the defects which he have developed in his peripheral vision. Secondly, a few patients do report some symptoms which have to be taken very meticulously and mindfully to understand that these could be signs of primary open angle glaucoma. For example, some patients may say that they see halos around the light, and that is because of slight corneal edema, which occurs because of the raised intraocular pressure. And some intelligent patients may give you the history of off and on accidents, and they may say that they are not able to appreciate something which passes by their sides. So these could be the very rare presenting complaints, but mostly it is asymptomatic. Now we come to the management of this disease. In this video, we will not go in classification and other causes of glaucoma. We are talking about just primary open angle glaucoma, in which there is no other disease in the eye, and the angle is open from where the aqueous humor is drained. So I am addressing the audience which already has a knowledge of anatomy of the eye and has gone through the primary open angle glaucoma at least once in the lecture or from the book. The main aim of the management is to achieve a target pressure, because in glaucoma we must remember it a triad of this disease, which consists of raised intraocular pressure number 1, typical visual field effects number 2, and optic disc cupping number 3. This is the triad of primary open angle glaucoma. We have no control over any other thing, because glaucoma is an optic neuropathy, and it is said that the damage to the optic nerve occurs because of a process of apoptosis, that is pre-programmed cell death. And the only thing which humanly is possible is to decrease the intraocular pressure, so that the proposed theories of mechanical and ischemic damage to the optic disc are prevented. And we do that by medicines, and mostly the first line of medicine which we use are the topical beta blocker eye drops, BD. And we have to achieve a target pressure. Normal pressure is 10 to 20 mm of mercury. If a reading of more than 20 mm of mercury consistently comes for a couple of times, then we should become alert, and we should go for other tests, that is visual field analyzing by the latest method, Humphrey method, which tells us the defects in the visual fields. And we may go for optical coherent tomography of the optic disc to rule out the early glaucoma, or we can go for OCT, optic coherent tomography, for retinal nerve fiber layer analysis, because the earliest damage occurs at the level of the ganglion cells, which literally, and ganglion cells are the one whose axons make up the optic nerve, and ultimately it is damaged. So our intention is to achieve that pressure which does not damage the intraocular pressure. The current pressure is a damaging. Maybe it is within a normal limit, that is 10 to 20 mm of mercury. If it is 24, then we will start with the beta blocker and we will check, and we will try to come it below 20. And after every 3 months we will perform OCT or and visual field analysis, and we will compare the results. And if the disease is static, then we may ask the patient to continue with the same medicine, or we can add the second one, which can be in our setup some like sympathomimetic drug, alpha-gun eye drops, or some other third medicine. We can add up to 3 medicines: beta blockers, sympathomimetic drugs, and some others. And prostaglandin derivatives is the latest medicine, but as it is very expensive in our setup, practically it is unfortunately limited to the people who can only afford it. But the advantage of that disease drug is that it's only once a day and usually brings the pressure down. But these medicines which I mentioned are not very bad and equally decrease the pressure. So we have to see other factors also while prescribing the medicines. If the pressure is usually the target pressure is 16 mm of mercury, and after which usually damage does not occur. If even at 16 mm of mercury damage occurs, then our target pressure must be lower than that at which the damage should not occur, and that may not be possible with the maximum medicines which can bring the intraocular pressure not lower than 16 mm of mercury, then we call it normal tension glaucoma, which is a subtype of primary open angle glaucoma. And for that, we will have to achieve a pressure which is around about 10 or a little below of 10 mm of mercury. And for that, we have to go for surgery, which is called trabeculectomy. It is a process in which we make an anastomosis between the anterior chamber and anterior chamber and subtenon space. So we allow the aqueous humor to drain through that passage, thereby decreasing the intraocular pressure mechanically. And this is our last resort. And if done properly and patient responds, the disease progression is decreased and sometimes it is stopped. In the end, the very important thing which you must remember, that glaucoma, which is in Urdu called kala motia, is the most common cause of irreversible blindness all over the world. And unfortunately, we cannot reverse the disease, and we can only decrease the progression of the disease. And in some fortunate patients, we can only stop the disease process. But unlike cataract, which in Urdu is called Sved Motia, is totally different, which is specification of the lens, and after cataract surgery and implantation of intraocular lens, vision is rehabilitated almost 100%. So these are very important things, and I hope this video would be of some advantage for you people. Here I will stop, and if you have any questions, please write in the comments box, and on the basis of which we will be discussing over other topics. For now, thank you very much.